Hello, everyone. I have always said that without gratitude, there is no happiness. If you are not going to be able to find gratitude, you're never going to be happy. For instance, if you have millions of dollars, if you can't appreciate what you have, you're not going to be happy. Hello, my name is John Lin. I'm a urologist in Gilbert, Arizona. Also, your host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. I am again hijacking a webinar. This is a presentation by Mark Painter of PRS Network. He is well known in the urology circles as the guru when it comes to coding, billing, practice management, and he is being sponsored by Boston Scientific to present to us implementation of telemedicine in the era of COVID-19. Just for clarification, I am not paid by anybody to do this. There seems to be some confusion. I am not sponsored by anybody. I'm simply presenting this information to you for your benefit. So just get that clear in your mind. All right, there's been so many changes within the last few weeks coming from Medicare when it comes to coding billing for COVID-19, as if it's not complicated enough to take care of patients. Medicare's rules are already complicated enough, and now they change it on us 3 times within the last few weeks. No wonder everyone is confused about what we can bill and what codes are acceptable, where can we provide the service, what platforms, and what is kosher, what is not. So I hope in the coming few minutes, Mark will be presenting this information to us and clarify and give us some direction regarding what is the currently known best way to code and bill for telemedicine services to Medicare beneficiaries. He's probably going to mention CMS 1744 interim final rule, or also known as 1744 IFC. As soon as the webinar starts, I will switch over the stream to the webinar. And let me go ahead and switch over as they have just started.
By thanking every one of you for joining us and taking time away from your families this evening. And most specifically, to thank you for everything that you're doing right now in these very unprecedented times fighting COVID-19. I know the entire team here at Boston Scientific is so very grateful for all that you're doing, and it's our pleasure to be able to bring you a program like this tonight that hopefully is our way of contributing in a very minuscule way comparatively to what you're dealing with today on the front lines. We're fortunate enough tonight to have 2 people that I get the honor of introducing, and the first one is Shashwat Banor, who is our Vice President of Global Marketing for our division. And then I'm going to ask Shashwat to say a few words, and then we'll turn it over to our featured presenter tonight, Mark Painter. Shashwat?
Thanks, Jeff. Like Jeff said, these are unprecedented times, and I'm sure you'd have heard the word unprecedented, an unprecedented amount of times in the past couple of weeks. We'd like to thank you for being here with us, and we'd like to let you know that we are here with you together. And one of the things that at Boston Scientific we are focused on right now is to make sure that all of us, our healthcare practitioner partners, physician partners, are equipped to do is to say, how are we going to be better off as a result of this COVID crisis? How can we make sure that we are coming out with things that we learn from this that we are going to use later on? We're not going to allow this crisis to go waste. And we thank you for all that you're doing for
That's right.
our
Let no crisis go to waste, folks.
For the world at large. And having said that, this is again really in service of the public that we're bringing, in service of you all that are on the front lines, and make sure that we bring our best to help you help patients. This is a technology-driven world. Telemedicine is going to have an important part to play now, and even more so in the future. So this workshop that we have with an expert is meant for all of us to be better informed, to be able to serve the population at large better in the future. Having said that, I turn it back over to Jeff.
Thanks to Shashwat for those words, and so true, every last word of them. As I said, it's my pleasure to introduce Mark Painter tonight. And Mark is the managing partner of PRS Consulting, the CEO of PRS Urology Services Corporation, Vice President of Coding and Reimbursement Information for Physician Reimbursement Systems, and CEO of Relative Value Studies. Since co-founding PRS in 1989, Mark has served as the primary coding resource for the PRS products currently produced and marketed in conjunction with 9 specialty organizations, including hotlines, coding manuals, quick reference tools, the internet-based app codingtoday.com, as well as various seminars. Mark has lectured to a variety of groups concerned with healthcare reimbursement, and his extensive knowledge of physician documentation, coding, and reimbursement issues has allowed him to assist insurance companies, physicians and their staff, legal counsels, actuaries, consultants in the medical industry. He also serves as an expert to legal counsels, biodevice companies, medical directors, and various pharmaceutical companies. During Mark's presentation tonight, please take a moment to utilize the Q&A function of the application for submitting any questions. I'm quite confident we won't be able to get to all of them in a limited time we'll have at the end of the night. So accordingly, at the end of the presentation, you'll find Mark's email address, and Mark would encourage you to follow up directly with him if we can't get to every question that's asked. With that, it's my absolute privilege to turn it over to you, Mark.
And we thank Boston Scientific for sponsoring.
All right, thank you, Jeff. And thank you, Boston Scientific, for allowing us this platform to share information. As all of you know, it has been rapidly changing. So we've been trying to keep up with everything. We're hoping that with this information I am sharing with you tonight, that we're now through the frontline hurdles that we've been through with major changes, and we're now a little bit more focused on just some of the, hopefully a few subtle changes that will come into play as Medicare tweaks what they're doing instead of such a major change. So I'll go ahead and get started. You saw the disclaimer. I am going to be using some information tonight from the CPT manual, so give appropriate kudos there. And then across the board, I'm going to be using information from the CMS final rule, the telemedicine fact sheet, as well as the information from the interim final rule. So I'll go ahead and get started. I'm just moving a few things around my screen so I can see better. Sorry about that. All right. So throughout the night, I've kind of broken our presentation tonight in a few different into a few different groups. After I get through each one of the sections, as Jeff mentioned, I'm going to encourage you to go ahead and put your questions in, or remind you to put questions in. But feel free to put your questions in as we go. And as Jeff mentioned, we'll get to as many of those questions as we can. And then for those that are left over, I will provide my email address and, of course, the PRS website where you can get some answers as well. So I'm going to start with telemedicine and then move into telehealth. And for tonight, you know, the terms telemedicine and telehealth get used in a variety of ways. And I've kind of broken it down really more so that we can have this discussion with a little bit more clarity. So I'm going to talk first about what I'm going to call telemedicine, which is the synchronous data with live audio and visual interaction for a remote visit. And then we're going to move into telehealth, which I am going to refer to as those encounters in which there's an asynchronous data exchange or telephone-only interactions. So Medicare has, in fact, with the interim final rule, actually separated these out a little bit more. We've got some clarification of what we can and cannot do. Certainly, we've got a few comments that have come back in that the way the payment levels are looking, they're not necessarily fair, but they are the rules that we are living under. And in fact, you know, it is Medicare, and fairness isn't their front end, but I will
Nope.
definitely put some kudos out that essentially under the Stafford Act, they have done quite a bit very quickly
It is extremely
to
impressive.
open up access so that you can continue to provide care to your patients, which is the overall or the overarching push here is to allow you to continue to care for your patients in the face of stay-at-home orders. And all of this right now that I'm going to go over are rules that are in effect during the public health emergency, or the PHE. We don't have a finalized time frame as to when this is going to end, but these rules, when they were put into place, were made effective on March 1st. So stuff that you learned tonight that may be a little bit different than the information we gave you in the very beginning may in fact warrant going back and re-billing claims. And we are doing that with some of our groups because the information has changed, and that's just kind of the way this is working. All right, so I'm going to start with telemedicine, and remember again, this is synchronous audio and visual. So first up, new patient visits. CMS has blanketly and blatantly stated that they will not enforce the requirement that they have as a law that patients have an established relationship with a physician provider providing telehealth care before they actually enter into an encounter with a patient. So this has really opened up the door. We had some questions early on that they kind of gave us a wink and a nod that it was okay to do, but they have actually put this in the final rule. So it is okay to go ahead and provide new patient visits to patients using audio visual. Established patient visits, and then you'll notice I did not include the 99211. That is not something that is allowed under the telemedicine office visits. There are different codes that are available to you for some of those interactions, but right now the 99212 through 99215, those are going to be your remote office visits, again audio visual with the patients. Now, the place of service has been one of those areas that was kind of flopped around a little bit, and they have opened this up so that, and they have given us some specific direction. So right now, the physician can indeed provide home health service, or office-based services or visits to the patient, even if the physician is at home when those telemedicine services are provided. Again, as long as you have the audio and visual, and the address that gets put in, because those of you who look at claims and look at the way things process, there is an address that is included for the place of service within which you provide the service. So you do not have to go out and register your home as a place of service or get an NPI number. What CMS has instructed is that even though you are providing the service from home, you are going to use your office as the rendering location in addition to the appropriate place of service code. So you don't have to worry about doing that. You can provide services from your home throughout the public health emergency. They also have, and this is one of the reasons I think they're really kind of leaning hard into that you need audio visual, is that they have in fact stated that you can use FaceTime or Skype during this public health emergency. These are not really HIPAA compliant applications, but as far as Medicare is concerned, because you're using these to provide patient care and continuity of care, those are allowed. Now you hear me talk a little bit later. I'm going to encourage you to adopt where you can HIPAA compliant tools, and you're going to want to use those as best you can. There's a couple of reasons for that. Number one, the HIPAA compliant issue is definitely waived relative to CMS, but there is some question as to how much leeway you're going to have with HIPAA compliance through some of your other payers, not from the payers, but potentially from your patients. So you do want to be judicious in when you use FaceTime and Skype. And if you can get to a HIPAA compliant tool, you'll want to do that. And the second thing is, and I'll talk about this a little bit at the very end, is, and Jeff mentioned it, as did Sashwa, I think telehealth and telemedicine are here to stay. They are solutions for a number of problems that we were facing before COVID, and we are going to still face those going afterwards, and especially right afterwards. And telemedicine, if you can get good at it, and a lot of folks are getting better very quickly, will be a tool that you can potentially use in the future. Maybe not as easily or under the same rules that we have right now. In fact, I'll guarantee it that it won't be there, but under guidelines that are probably a little bit more relaxed than what we had prior to the virus. So again, just want to emphasize that E&M codes can be reported for remote services to any patient, new or established. Now, they did specify in the interim final rule, so this was a change that recently came into place, that they are going to partially adopt the guidelines for evaluation and management codes that are coming in 2021. They're not going to adopt the full set of rule changes, but they're going to partially adopt those. What that means is that time has changed in its definition. Whereas before you had the requirement that it was all face-to-face time, so you would basically just time the screen time you had with the patient, and that 50% of that time needed to be spent in counseling or coordination of care. That has been suspended and replaced with the guideline that you can use time as time that is spent completely throughout the day in dealing with that patient encounter, which means the time that you spend preparing for the visit. Now, this is about physician time, or if it's a mid-level, the mid-level time, the time that the billing provider is going to spend preparing for the visit, the time during the visit, and the time after the visit reviewing data. Those are all able to be included in the total time used to select the level of visit. You are going to want to record that time within your electronic medical record. They have also said that your medical decision-making is now the only component that you really have to worry about when selecting the level of service. That means that the history and physical exam components are not part of your level selection. So what you record is based only on what you medically need, and the level is selected based solely on the medical decision-making that you do. Now, we are using the medical decision-making criteria current in the guidelines. So those of you who have been to our courses, those of you who have had training across the board, know that these are the medical decision-making rules and the point systems that have been in place for a while relative to data, the presenting problem, and of course the risk. So base your component selections on MDM only, and the time can be used as time spent throughout the day relative to that visit spent by the provider. Now, if you are unable to establish video connection, we get this question quite a bit. Unfortunately, the way the interim final rule reads is that if you are unable to establish video and that you use telephone only for a visit, be it a new patient or an established patient, you are instructed to use codes 99441 through 43. These are time-based codes for telephone only. Now, one of the things we get a question about sometimes is, what about that blended visit where you tried and actually were able to establish an audio-visual connection to do a portion of the visit, and then maybe the entire neighborhood flipped on Netflix and that crashed and you moved to the telephone? Those are visits that I think you can still move into your office visits, because a portion of it was done live audio visual. But if the entire visit is on telephone, you need to move to the 99441 through 43 codes. The other big change that came into play in the interim final rule is the place of service that's used to report these services. Previously, Medicare had indicated they wanted you to use the place of service 02 with no modifiers. At this point in time, they are instructing you to use the place of service 11 for office visits, and that's regardless of the location of the patient or the physician. And I want to qualify that a little bit. Obviously, if you are seeing a patient that is in the hospital and you're providing interactive telemedicine to a patient in the hospital, you're not going to use place of service 11. In those cases, you're going to use the place of service that would more accurately reflect what was happening in a face-to-face visit. So you would use place of service hospital or place of service emergency room if that's in fact where you're doing the audio-visual visit. You are also instructed to append the modifier 95. The modifier 95 is what indicates that the service was provided with audio-visual or under telemedicine remote services. Co-payments have been a subject of a number of discussions. Medicare has indicated that you can waive your co-payments for your Medicare patients. This doesn't mean that Medicare is waiving that responsibility for the patients. Actually, they've been clear that for traditional Medicare, the patient does have a responsibility for their co-payment and co-insurance. Obviously, you have the secondaries that can be billed for those services, but you can waive them. Whether under non-PHE times, you are supposed to try and collect those unless there's a financial hardship. So you can waive them, but that is information there. That is money that if you do not collect, and it is part of what is required, that you will not be privy to. The other thing that has been a little bit of an issue across the board is consent forms. Medicare and the interim final rule said that they're giving you some time to collect those forms that you typically obtain from a new patient. Your financial forms, your HIPAA forms, your policies with regard to telemedicine. You've got time to do that even after the service is provided. You can get a blanket annual consent form signed for the year, but that can be done afterwards. I am going to encourage all of you to put into your medical record that verbal consent was obtained during the live interaction. That will give you some of that. A lot of you can build that into your electronic medical record. Now, I'm going to also encourage you to look very carefully at how you use this, in that you want to make sure that you're really treating this as if it were an office-based visit. So you're going to want to open an office note within your electronic medical record, document what is needed for the history and physical, but then build out your assessment and plan appropriately, and then add in that verbal consent as well as the indication that you provided the service using audio and visual services. That should be an easy macro for all of you to add into your electronic medical records. Relative to other payers, and in other payers, I'm going to lump in Medicare Advantage plans. Most of your private payers are following Medicare's lead, roughly. There may be some things that they do a little bit differently relative to processing.
Very roughly.
Some of the payers are still going to require place of service 02. Some are going to require place of service 11. What we're doing is watching very carefully what passes through the edit screens and then what comes back on the explanation of benefits or your EOBs. You may find that the payment levels differ based on the place of service. If you can submit with place of 11, and that's what we're really going with on our first time through, unless we read on their websites that we should use place of service 02. We're going to use place of service 11 first time through and modifier 95. But there are some payers that just aren't as upgraded, and they may require modifiers GQ or GT. Medicare Advantage plans. They have to allow at least what Medicare does, and Medicare has instructed Medicare Advantage plans to cover the co-payments. So that's a little bit different than what Medicare is doing, which means they're waiving the patient's responsibility, but then paying you the full allowed amounts for the Medicare Advantage plans. A lot of your private payers are also covering co-payments for patients as well. So you want to watch that. Those of you in Texas right now, Blue Cross and Blue Shield of Texas has elected not to cover the patient's co-payments. They may do that in the future, but those are some of the nuances that we see with some of the payers. I am going to tell you as well that your payers are short-staffed. They have work-at-home orders as well. It's been a real pain to deal with the payers. We've had to wait significant times on the phone to get prior authorizations and referrals for some of the inpatient and in-person visits. We haven't yet in across the board seen that these have been requirements for all of the telemed visits. But at this point in time, we're not taking many chances with our IPAs and how they've behaved in the past. And unless we obtain a direct directive from the payer, we are still getting referrals, authorizations, and those types of things that are appropriate for that particular payer in face-to-face visits. We're doing as much as we can through the web and through portals because waiting on the phone has been a significant chunk of time. Now, the other thing we've got a lot of payers. Some are asking for holds as they reprogram. And we've been informed that some of your Medicare carriers are not yet fully operational with the ability to process some of these codes that were non-covered by Medicare that I'll cover in a minute, as well as some of the claims that process through with a 95. Now it looks like people are submitting some questions. I'm going to encourage you to again, remind you to use the Q&A panel here if you have questions regarding reporting of telemedicine services. Now, moving on now to operational services. You may kind of detect a theme here. You do want to mimic the inpatient office experience as best you can for the patient using audio and visual. But we're encouraging you, and a lot of offices have found a great deal of success in trying to mimic the in-office experience from a flow perspective. Taking your patients, running them through your scheduling and your front desk folks, having those patients understand that you are collecting the information that they need to process the schedule, to schedule the patients, collecting all of their information, because you're not going to get a chance necessarily to scan their insurance card or their ID. So you want to get that information up front, especially if they're your new patients. Ask your established patients if they need updates, if they've had any updates to their insurance since the last time you saw them. Get that information into the system and run your eligibility checks before the visit is occurring. So again, kind of like you would on a normal office visit, but make sure you're doing that with that kind of that extra check in place. If you haven't been doing eligibilities, then on the day of or the day prior, you can use your support staff, be it your front desk staff or your back office staff, like you normally would in an encounter, to update the patient's history and load it into the patient's medical record if you need that. We have some offices that are using the services like DoxyMe or Chiron, where you have the ability to kind of hand off that call. So that gives you really have to make your kind of whoever is handling this as a little bit of an expert to work the patient through getting established with the audio and visual so that they're ready to go at their office time. And then it can be handed off to the patient or to the physician or the APP to actually go through the visit. This definitely helps with office flow. We've noticed, early on as people start adopting telemedicine, that these visits are taking a little bit longer as you go through this. the overall process. So that was one of the things they found that helped quite a bit. In addition to providing patients with videos on your website recorded by physicians or faces they're familiar with in the office that kind of run them through the instructions on how to sign up and deal with the remote encounter using audio and visual. So the more you can get them set up ahead of time, the better off you're going to be. Now, the other thing you want to remember, and again, this is probably one that you can't get away from as far as mimicking your in-office experience, is if you're not somebody that runs on time, or you're still seeing patients in the office, so you're dealing with interruptions and you're dealing with management interruptions, so you're running behind, you're going to want to let your patients know that there is a window of time that you're going to be there. I think you get a little more leeway in the telemedicine visit because they're not sitting in the waiting room. They're sitting in their house waiting for you, so they're a little more comfortable on those wait times. So be good at communicating with the patient and really establish realistic expectation. Now, when you open your encounter notes to build these visits, a few cautions. Your templates are built for your in-office experiences. You may not do, in fact, you're not going to do the same history and physical exam for most of your patients. So those are things that you want to be careful of, that you don't kind of preload your templates and you're recording more than what you actually do. So make sure you use your templates and your EHRs wisely. And again, build your telemedicine language in and record where the patient is, that the fact that they're made aware of that it's a remote visit and they understand and provide verbal and consent for the visit, and indicate whether it was done with audio visual or with regular audio services. And then really use your electronic medical record the way you normally would to dictate your standard assessment and plan and the data that you review. As far as frequency and timing of the visits, and we're talking now about the same patient being seen multiple times. One of the things that you're going to potentially open up is a little bit of a window to availability. A lot of patients think that because they're on the web 24/7, that you're sitting there on the web 24/7 and ready to provide services. So you want to make sure, again, that you try and keep it to your standard office-based visit. I will tell you, a couple of folks have said as they're going through all of this that one of the biggest time issues that you deal with is these patients haven't had a lot of contact with the outside world, and they're very interested to talk to you about how COVID's affecting your business and affecting your family, all those things. Not that you shouldn't do those things, but be aware that those are time issues that will creep into your schedule. So you do want to try and keep them focused on urology services. And then as far as frequency of visits, you want to make sure that they understand that you can only visit with them for things that are medically necessary. And you want to bill those visits that are medically necessary. And we've got a few options to do that. But we do have a few restrictions on some of the telehealth codes relative to the standard office visit code. So there are no specific blocks that are required. And in fact, they did remove some of the blocks for how many times you can do a telemedicine visit for inpatient services, so that you can do those as if you were seeing patients face-to-face. So again, treat them like face-to-face visits as far as how often you see a patient as well. Also, with telemedicine visits, you're still going to want to, just like the office visits, you're not going to be able to charge for those phone follow-up calls that are really related to those E&M visits, when you're calling back that everything's fine, the tests are negative, those types of things. But you can charge for those visits where you are indeed focused on providing the patient care using the office visit codes, as we said before. And again, we've got some telehealth visits that we can talk about specifically. Now, the last one I'll talk about is if you have a visit that starts maybe on a telemedicine visit or a telehealth visit, but for whatever reason, you're not getting the information that you need, and you basically need to have the patient come into the office. If you're having the patient come into the office for treatment or to drop off a urine specimen or something like that. But so you really complete the telemedicine visit, go ahead and bill for the visit. But if you actually you're not able to really complete a telemedicine visit and you're going to bring them in-house to actually do an in-person visit, then that's an encounter that you wouldn't charge for. Right, again, I encourage you to add questions as you need there. And I'm going to go quickly. I'm running a little long-winded. So with telehealth visits, and again, these are asynchronous visits. Medicare lifted the restriction that this could only be established patients. You can charge these codes for newer and established patients. They do not require that the patient is the initiating individual. The office can initiate these visits as needed. But you are going to want to make sure that these interactions are not the result of a previous visit, or they don't result in a move into your office at the next available visit. And again, I'm going to remind you, even just like the telemed visit, you're going to want to make sure that you document that you obtain consent from the patient during that visit. The codes that you would use for these telehealth visits are the G2012. Again, this is a very brief telephone visit, and it is going to be a little bit more of a check-in visit across the board. You'll see in a minute there's another set of codes that you are able to use that are worded virtually the same that Medicare has opened up coverage for. And then the G2010, these are for visits in which maybe the patient sent you some data or sent you an image, and then you're calling them back with your interpretation of that video or that image. So it's kind of a broken visit, if you will. These are some of the codes that Medicare has just opened up. And I will tell you, I've gotten some information from some folks that these are not yet loaded into their system. So they may reject at the clearinghouse level and may have to be resubmitted when they load them in. Now, these codes, the 99866, notice that these are codes for telephone assessment and management provided by a qualified non-physician health care professional. So these are those nursing visits that you would deal with, where the nurse and your non-NPI people are providing these services to the patients, and they're maybe just checking with you that the advice that they're giving them is fine. So that's what these codes are for. The telephone only visits for physicians and APPs should be reported under these codes, the 99441 through 43. Again, they are time-based. One of the things that you want to make sure with both telemedicine visits and telehealth visits is that you're not adding in your setup pre-op time or pre-service time that's being provided by your support staff. This is the time that's actually spent by the person that's actually going to charge for the visit. Now, this next set of codes are codes that are billed for other telecommunication interactions. These will primarily be provided through your patient portals. And notice that these are a little bit different. These are kind of an established vision for up to 7 days, and it's for the cumulative time for a 7-day period. So they designed these codes so that if a patient were to put a query into your website and ask you specifically, hey doc, I got this going on, you respond, give me a little bit more information. They give you a little more information. Maybe you need a little bit more. And then finally you get to a point where you're able to prescribe them some medicine. All of that time that you spent over that 7 days is added together to select these codes. And your documentation is going to include the total time that you spent relative to that that particular encounter over that 7 days in that particular patient. And then the G20 codes are for the time that's spent for your nursing staff to do those interactions. And again, just check with the doctor. Now, if the physician is not the typist, just like we have with the scribes in all of this, or your APP is not the typist, you still clock the physician time, but it is allowed for your nurse or someone else to be your typist to actually put those that information through. again, encourage you to add any questions there. Now, before I get to talking about or opening up to questions, just wanted to bring up a few more issues that came up within the interim final rule and some of the other things that you might want to do from the operational side. Hopefully, none of you are going to be infected or are infected with COVID. But if you are and you are not you're serious enough that you're infected, so you can't go into the office, but you're not serious enough that you can't provide services from your home, they did open up the Incident 2 rules in such that if you are able to use audio and visual supervision of your staff at the office, you can allow your staff to provide services while you supervise them. So, if a patient needed their 3-month Lupron shot and it made sense for them to come to the office, you were unable to get in there, but your nursing staff was there. If you had an audio-visual communication to supervise the shot and the activities there, you can charge those services Incident 2. We are going to, in the end, you're going to be governed by a couple of different things here. Number one is availability of staff and willingness of staff to actually staff the office and whether or not you have the audio-visual communication. And then, of course, the other thing you're up against is the stay-at-home orders and how that can affect things. And because of that, they have also said that if you can do audio-visual supervision of a contracted individual to go to a patient's home to provide those services, you can also provide those services incident to you for those that are individuals that are contracted for you. Now, be careful of that. Obviously, some of those patients that are having those services done, those may be provided by home health. So you've got some of the same rules that you would have, again, as the face-to-face. Maybe you would be able to bill an E&M visit, but if they're normally giving those shots, you can't also do those incident 2 if they're the ones that are normally providing those. Again, I mentioned to you a little bit about phone calls by nursing staff and your MA. You want to use those special codes, the 989 series codes for those visits that are done remotely by your staff. I think you can be very aggressive, and a lot of folks have done this. And by aggressive, I don't mean angry aggressive, but to be very forthright in offering your patients telephone visits. Really, most of the patients are very appreciative of the ability to connect with you when they're homebound and for the PHE. So feel free to use your websites, your emails, text messaging to really encourage your patients to use the portal and to take advantage of the telemedicine visits. You can also do this as you're doing your patient reminder calls if you have some of your schedule booked out throughout the month, to offer them a telemedicine visit and instead of trying to reschedule them for another point in time. So do aggressively message these options to your patients. And as I mentioned, some offices are going further and really trying to provide some additional support for your patients on how to do a telemedicine visit, and offer some of that information through their portal. Remember, these folks, a lot of them are sitting at home and they're spending a lot of time on the internet. Now, not all your older patients are there, so you're also going to be able to get on. Not all your older patients are on the internet, but they are able to use the phone quite a bit. So making sure that your front office staff is well versed on how a patient can use or access you through telephone for services that they need for their continuity of care. Now, the other thing I'll mention very quickly is even though if you're using telecommunication services through your portal, a lot of that information gets recorded within the electronic medical record. You are still going to want to record the necessary information that you need for continuity of care, maybe in an office visit note, so that as you see the patient the next time through, you don't have to dig all the way through the chart. So don't get sloppy. You are going to start to see these patients again in person. And then the other thing that you want to make sure that you're doing is recording the time appropriately in the electronic medical record for all those the telehealth visits that occur. Now, as I close, I do want to focus a little bit on the longer term. As I mentioned in the very beginning, I do think telemedicine and telehealth are going to become more of a part of medicine. And most of you have heard me say this before the COVID came along. But now that people have gotten a taste of what they can do and what we can provide, I think this is going to become a part of this. And when you think about the potential of what's going to happen as our stay-at-home orders lift and the surgery centers start to open back up, we're assuming, of course, that the manufacturers are going to start their production roles getting up and running to keep up with the supply of what's needed and start to bring back those supplies. You're going to have a lot of pent-up demand for the elective surgeries that the patients have not been able to pursue. So being able to stay in touch with some of your patients that don't need that while you're in the operating room all day, telemedicine may be the way to continue to keep your patients or to keep in touch with your patients while you're juggling a full schedule. So as you're doing this and as you're required to do this to keep up with your patients during the shelter at home and the public health emergency, take the time to build your systems and protocols and build the systems and templates that you need to use these in the future. This is why, ultimately, if you have to use FaceTime or Skype, go ahead, because some of your patients aren't going to have that capability. But if you can, start integrating the real HIPAA compliant technology that you've got. Develop your protocols and how to do that with your office staff and how to move patients through appropriately. You're going to want to do this anyway because you're going to want to try and get back up. And I can tell you, we have a number of folks that are telling us that they're back up to 80% of their schedule, some even to 100% of their normal daily schedule using telemedicine because they've gotten more and more efficient. So I do think this is going to be a part of it. Use this time now to really develop your processes, your procedures, and your protocols, because I don't think it's going to go away. Now, I don't think it's going to continue under the current environment with the wide scope that you're going to be able to provide. We're going to have some restrictions put in place. So you are going to be required to do a few things differently, but I do expect that these services are going to be part of healthcare for the near future. All right, so we're going to move to questions now, and I'm going to ask: can everybody see the questions, or do I need to read the questions?
Mark, it's Jeff. I can't see them on my end, and I'll make a little bit of an audible if it's okay with you. It looks like there's about 28 questions in a queue. So maybe if we kind of scan through those and see if there's a common thread from each of the various sessions that you talked about tonight. We obviously won't have time to go through what's now 30 questions.
Okay. All right. So one, could you have the patient do a urine dipstick at home and use that information to triage treatment? People use home and report to the OBs. So obviously you're not charging for that urinalysis because you didn't actually do that in your CLIA waived facility. But certainly you can use that type of information to make decisions. I think I answered the question relative to HMOs and referrals. So I'll skip through that. Patients recording video and home visits legality. So I'm assuming you're talking about maybe the patients recording those visits or you being required to record those visits. You do, ultimately you're not required to record video and audio visits. you can document the visits as to what's been done. But as far as looking at asking a patient, asking you to record those visits, it is one of those HIPAA issues that if they have that recorded, they need to be careful about what they share. So, it's one of those areas where my immediate reaction is I would be very careful of that. And I might consult my medical legal carrier to see whether or not that should be recorded and what restrictions need to be put in place. We've got a question about testosterone. Essentially, they have refills that must be followed up on, and they must be seen in the office for follow-up. I think there's going to be some leeway as far as what medical necessity allows for during the public health environment. And I think in the end, you really need to do what's best for your patients across the board in continuity of care. If you can stage them so you can see them, and in most places, medically necessary visits are one of the reasons that they can leave the house. And if you're capable, you can certainly bring them into the office. But ultimately, you want to be very careful about the health of your employees, yourself, and the patients. So I'm going to say that you want to use your best medical judgment and double check with your carriers there. The comment that Doximity Dialer now has audio-visual chat, which is great. So somebody is using the modifier GT and not the 95. Medicare said that they would like to see modifier 95, and I think that's appropriate for Medicare. Modifier GT may be appropriate for some of your payers. So check with your payers relative to those. Clarification on place of service 11 versus 02. So generally on the back end processing, place of service 02 is going to usually process at the facility rate, whereas the place of service 11 is going to process at the non-facility rate. The guideline that we're given in the interim final rule is you are to treat those visits as if you were going to see them in person, use that place of service. So for most of your office visits, they're going to be place of service 11. For your visits that are telephone only, you're going to want to use place of service 11. For some of your teleconference calls or your 9942 series, you're going to want to try place of service 11 and find out if those actually go through. So there's going to be a little bit of experimentation as they iron out the kinks, but certainly try and use those. As far as going back and rebilling, I'd look at did the claims process the way that you billed them, whether you use 95 and 11 or 02 and GT. Look at how they process. If they did not process at the non-facility rate, or they were denied because of place of service, then go back and resubmit those claims. We are actually going back for almost every claim that was submitted prior to the interim final rule and changing the place of service from 02 to 11 and using the 95 modifier for anything that we use 02 and no modifier for that was an office visit. And that may be a strategy you may want to adopt as well. Clarify the difference between 4.4 codes and 4.2X codes. Hopefully you got that from the presentation. Telephone versus telecommunication and the other visits, telecommunications through the portal. Are out-of-state visits being covered? Medicare says yes, and most of the payers are allowing for that, but state rules are still overriding. So you're going to want to check with your medical legal carrier to make sure you're covered to provide those visits. And you want to be careful about the state that the patient is located in and what their rules are. Most states are lifting those requirements because of the shortage and because of the stay-at-home orders. So double check that. Any
Beware of the medical
recommendation for
malpractice
HIPAA
carrier, too.
compliant platforms? They use Helo, but it can be clunky. So generally the information that we've been given to folks is, number one, check with what's integrated with your EHR. If it's available and reasonably priced, and that means, close to free, because there are a lot of free services that are out there that are working pretty well. Then you can look at those as kind of first choice because they're integrated. Beyond that, I would have to say that doxy.me, doxy.me, is one of the ones that we've had the most experience with. It's easy to use, easy to adopt, and free at the moment, although there are in-app purchases, if you will. But we have folks that have kind of a little, if you want a little bit slicker interface and some of the information that you're willing to pay for this longer term. As far as equipment, Chiron has been one that's been around for a long that we've used quite a bit. There are a number of other platforms, and certainly, some of Teams and Microsoft, some of the services that will assign a BAA with you are services that you can use. So the closer you can get to the patient's end with some of those, those are what I would look for. And by the way, we do have on our website, which I'll give you now, the prsnetwork.com, a list of services that we have recommended as well. Please exchange the difference between phone calls to patients and results disk management versus the AV visits. Essentially, hopefully I gave you enough explanation through there in that audio-visual visits, think of them as if you're providing real analysis and treatment, if you will, kind of like, we kind of sometimes look at modifier 25, that it's significant and separately identifiable, and you're doing audio-visual from everything else you perform, go ahead and bill the audio-visual visit. If it is simply a follow-up and really was connected to something else, and you would have done it anyway based on an in-person visit, treat them as bundled. What is NPI2? Oh, an NPI2, NPI2 is the number that's assigned to your facility. Okay. Any comments on private insurers in California? So in California, just like a lot of other states, most of your private payers are covering telemedicine visits, and actually at the directive and the direction of your governors. Not only are covering your visits as part of your contracted, your covered IPA plans, but they're covering your co-pays and your co-insurance. So, ultimately, if you're contracted with your healthcare provider, check their websites. But realistically, most of your PPOs, HMOs, and IPAs are covering telemed visits, and mainly because they don't want to incur the cost of having their patients get COVID and go to the ER. So they're being fairly liberal, and a number of them are allowing even telephone-only visits. If you don't have services covered and you can collect remotely, those are things that you can charge for. I mean, those still remain open, but you want to check your rules. And Jeff, I don't know how much longer you're going to allow me to go. I got a few more minutes, right?
Yeah, I think so, Mark. I'm watching the participation, and we're not getting much drop off at all. So if you want to go for another, 5 minutes, give or take, at your discretion, that'd be fantastic.
Okay. All right. Does MDM complexity in lieu of time spent apply to new patient visits as well? The answer to that is absolutely yes. The interim final rule waived the history and physical for both new and established patient visits. So you can go on MDM or time for both new and established patient visits. For the E&M telemedicine visits, are those required to be patient initiated? No, they are not. They can be scheduled appointments. and you can call them, and you can switch your scheduled appointments to telemedicine visits. Also, the telehealth visits that we talked about that include the kind of the caveat that those are intended to be patient initiated. Those issues have been waived. So you can use those codes as well for that. And certainly you've got your telephone only visits, the 994 codes. Those can be physician initiated or scheduled. So and ultimately, again, I'm still going to encourage you to go ahead and do your outreach so that your patients are reaching out to you via telemed and telehealth to get their healthcare needs met. What documentation is required for a non-physician, non-APC, and what does a medical assistant documentation for the G206 codes? Ultimately, you're going to document those similar to the way that they document nursing visits. Those codes, the G206 through 63, are time-based, so you're going to want the nurse to record all the time that they spent in that transaction, or the 989 codes. They're going to want to record the time that they spent on the phone, and you're going to want to have them document, similar to the way you are, what was done. They're going to want to open a visit just like they would a nursing visit in your office. Can telemedicine be used for inpatient consults? So yes, they can. We still have the audio-visual requirement for the 99221 through 23 and the 99231 through 33. But we do have some telephone-only visits. By the way, those would be billed with place of service 21, inpatient or outpatient 22. And they are going to pay the facility rates, although they don't have a non-facility rate, so that's not a differential. But you also have the G02 codes. I think it's 4645, 464748 or 454647 for initial, and the G04, I'm going to say 01. I don't remember those off the top of my head. I'll try and get those codes over to you as well. In fact, I can maybe I'll say that I can get that information to you. But there are some G04 codes that are available. Excuse me, G024 codes, G0241 and G0247s. Those codes are out there, and we can get those over to you for telephone only visits in the inpatient setting.
Hey, Mark.
Yep.
Just want to be respectful of your next engagement. So if it's okay, I'll finish with one final question here. And it's from a physician who says, I use a lot of questionnaires in my care, IPSS, SHIM, etc. What are the successful ways of using these tools via telemedicine?
So if you have the ability to give your patients those forms through your patient portal and to get those delivered back to you, those are certainly ways that those can be incorporated in your medical record. Otherwise, what we've seen people in the operational side do is use your support staff, either your front desk folks or your back office folks, pre-visit to actually verbally go through those questions and record those answers either by phone or on audio visual, and incorporate those directly into your medical record if they're set up that way, so that you have access to that information into those forms. So it's a manual process now. You've got to kind of insert somebody unless you've got your patient portal set up to handle those.
That was great. Thank you, Mark, so much information, so much in-depth information to go along with that. This actually looks like it's going to be the first in a series of webinars that we'll be hosting over the next couple weeks, next couple months. Invitations via the opt-in email, such as many of you received tonight, as well as through social media. One of the ones that we're expecting to be able to roll out very shortly is a couple of programs coming from physicians that have been hit in specifically hard-hit areas like Milan. So look for that through the various channels as well. If you would, I know there's still a large number of people online. There should be a poll that starts appearing here, which is just 3 very quick questions. Sincerely appreciate it if you would take the time to fill that out, because it really does help guide us. And again, as I started, I want to close, and that is by sincerely thanking each and every one of you who are on the front lines right now. I have a wife who works in a hospital with patients, and I see the fear and the angst and the uncertainty with her on a daily basis. So again, thank you just so much for all you do. Be safe, be well. Good night.
Good night.
All right, guys, let me switch on over. I'm doing so many things in the background here, so bear with me. There are a ton of questions that are still unanswered, and I'm going to see what I can do personally to try to answer these questions. All right, let's see. Where was Mark? Where did he leave off? There were a lot of questions. So bear with me for a second, guys and gals. He left off. He skipped a bunch of questions, and there were a lot of them. Sorry. I'm trying to catch up here. All right, here we go. If we are looking at time, okay. Jonathan asked, if we are looking at time with the patient and time preparing for the patient, if the MA spends time with the patient to get medication updates, etc., does that count toward the total time that we can then bill for the visit? So I'm assuming that you're talking about E&M visits under the public health emergency of COVID-19, and that is time for the provider who took to take care of the patients. So if I'm not mistaken, that is time by the provider, not your staff. It does not include your staff's time. Let's see. Let's skip down here. Mark asked if is Doxy.me, which is simple for patients to use, adequately HIPAA compliant. I will tell you that it is HIPAA compliant. As a matter of fact, if you are a member of the Thriving Urology Practice Facebook group, I specifically made a post with graphics telling you where to click to get your free HIPAA compliant BAA form on Doxy.me. Using the free version, you can self-generate a business associates agreement, and it is a HIPAA compliant 128-bit encrypted platform. I am not associated with them. I do not work with them. I have no financial interest, but I do use their platform using the clinical version. So there's the free version, there's the clinical version, and the professional version. The clinical version gave me some advantages. For instance, if you don't want to text or email using your personal email or your staff's email, you can go through the clinical version, the paid clinical version, which is, if you pay a year at a time, is currently under $350 a year. Come on, it is dirt cheap. You can use that version. You can email and text through the clinical paid version of Doxy.me to send the invite for the patient to engage you in telemedicine. Jennifer asks, what is the best way to document 99441 through 3 visits? Are there certain required components? No, those are time-based visits. And there's been a lot of questions on 99441. These are time-based telephone-only visits that you can use during the public health emergency of COVID-19. I don't know how long this is going to last. So until it works, continue using it. Medicare has not traditionally been paying for 99441 through 443. And these have to be provided by qualified healthcare professionals. And just give you some rough reimbursement numbers for a 99441, which I believe is 5 to 10 minutes or something like that. It pays $14, 99442 pays $28, and 99443 pays $41. You can look that up. Look up the particulars in your CPT manual regarding what are the requirements and criteria under which you can bill for these services, 99441 through 443. Jennifer asks, Ashish asked, reimbursement for phone visit 99441 seems poor. Many urology patients decline video visits. I will tell you, I agree. I just read you the numbers. They don't pay very well. I will tell you my personal experience is that all of my urology patients love audio-visual telemedicine, and I specifically asked them, is this type of visit okay with you? Would you prefer an inpatient visit? And none of them, during the COVID-19 crisis, none of them have said that they would rather come in person. they all welcome the ability to engage with me via telephone and video or video. Is there, Jackie asked, is there a code for incident to services by MDs, by MD or by a nurse? I think Mark covered that very well. There's incident to services that you can bill. It's also, if you, like say, I fielded a question in my DM by a urologist who practices down in rural Texas, as well as he covers multiple locations. He said, can I remotely supervise my nurse practitioner to provide a Lupron shot? The nurse practitioner is at the remote site. I am at some other location, but I can remotely monitor that interaction. And currently under the PHE, or public health emergency, that answer would have to be yes. Okay, Amber asks, can you please state again regarding time-based billing, and that it doesn't just include the face-to-face time, but you preparing during and after the visit. Okay, so during the public health emergency, according to CMS 1744 interim final rule, this is a partial implementation of what is about to come in 2021 relative to E&M coding and billing. Under the public health emergency, during this time period, you, the provider, the qualified healthcare provider, meaning physician or an APP, advanced practice provider, you have the ability to use time-based billing. And that includes not just the face-to-face time, and also that face-to-face time does not need to involve greater than 50% of that time involving counseling and coordination of care. That is out the door, okay? Under the current PHE emergency, you can account for the total time that you spent, including the time that you used to prepare the records and also the time to coordinate care after the face-to-face encounter, virtual face-to-face encounter is done. Andrew asked, do patients need to be formally scheduled in order to bill a charge for telemedicine or telehealth? Okay, when it comes to E&M 99201 through 215, these are the traditional inpatient traditional in-office new patient and established patients. You can formally schedule them for your E&M visits. However, there are some codes like the G2012 and I believe the 99421 ones. These are supposed to be patient initiated. So they are supposed to be patient initiated. And when they initiate the call, it doesn't mean, like Mark said, it doesn't mean that the physician or APP or the qualified healthcare professional needs to be on the phone or the computer all the time to take that incoming call. Your staff can take that message and then schedule the patient because it was initiated by the patient, and then now you schedule them for the visit. And if the code is appropriate, if the service provided is appropriate, it's a time-based telephonic only code. If it's appropriate, then bill that code. And yes, in this instance, you can schedule the patient for that type of visit. Okay, Kelly, can you verify that when we bill for telephone services because the patient doesn't have access to an audiovisual, we need to use the 99441 through 443? Yes, that is correct. Instead of the 99201 to 215, that is correct. Along the same line, if the call started off as audiovisual and the connection is lost, and we need to finish the call only with audio, can we bill the 99201 through 215 codes? Okay, just about a week and a half ago, Mark said the spirit of the law was that if you started the audio-visual and you lost connection with the video and you revert just to audio, it used to be that he recommended that you could use a 99201 through 205 code. However, in light of the implementation by Alex Azar, of Secretary of Health and Department of Health and Human Services, CMS 1744 interim final rule, that kind of changed things. So right now, if you started, you say you started audio visual, everything's going great, but then you lose the video, you should not bill for a 99201 through 99215 code. You should revert back to one of the telephone only codes. Cynthia asked, if you have residents Can they do telemedicine, and what is required for documentation of the attending? You know what? I believe I read that somewhere in the 221 pages of the CMS 1744 IFC. I know there's specific. That thing is such a broad document. It even covers residents moonlighting and electric wheelchairs and durable medical equipment. It's a very big document, but I believe that is covered in there. So I'm sorry, I don't know that off the top of my head. Andrew asked, does coding level based on medical decision making only also apply to the new patients? Yes, I think Mark answered that. Yes, it does apply to new patients when you are doing 99201 to 215 visits. Ron says, can you clarify again? I can staff a Lupron injection in office remotely. Yes, I already covered that. Rupa, Dr. Kitchens. Is G2112 and G210 codes only for nurses? No, as a matter of fact, G2010 and 12 are for qualified healthcare professionals, and they're telephone-only codes. G2012 is a patient-initiated code that should not have started. A problem that you're addressing should not have started within the last 7 days from a previous E&M visit, and does not result in an E&M visit within the next 24 hours or at the next earliest appointment. So read the CPT description on what allows you to do the G2012 and G2010 codes. Shannon asked, for new patient E&M codes, what are your thoughts on the physician or the physical examination? What is the best to document for the video examination? Okay, Shannon, you probably missed the very beginning portion. This is a crucial aspect of this new implementation, CMS 1744 interim final rule. For new patient E&M codes, no physical examination documentation is required. I repeat, under the public health emergency of COVID-19 and under CMS 1744 IFC, for an E&M office visit or E&M telemedicine visit, you do not need a physical examination, nor do you need to document a history. The only thing that drives E&M codes right now under the public health emergency is medical decision-making. So you better bone up and you better understand what medical decision-making is and how that can drive your final E&M codes, because you do not need a physical examination anymore for E&M telephonic, or I'm sorry, E&M telemedicine visit. Jackie said, we have patients that must come in because they cannot give themselves a shot. Well, of course, if they need a shot and they cannot self-administer, obviously they need to come in. Now, here's the other thing that is really important. Your patient should not be forced to undergo a telemedicine visit. You should offer and document the fact that you offered the patients the option of telemedicine and an in-person visit. And I do that for every single telemedicine visit that I provide. I document that I did offer the patient as part of the verbal informed consent that I obtain from the patient. Dr. Seskin says, or asked, do we need to get a BAA for every patient? Is there something that we need to officially to document that we did a telemedicine visit? So the first question is, do you need a BAA for every patient? No, the BAA applies to the telemedicine platform that you use to complete the visit. Is there something that you need to officially document that you did a telemedicine visit? I do it in the assessment and plan portion, in that I document that this visit is telemedicine, and I obtained the consent from the patient and I told the patient risks, benefits, etc. Amit asked, how much is the difference in payment between telemedicine and telehealth? Well, that's going to obviously depend on the level visit. And if you listen to one of the questions that I answered earlier, or somebody stated simply, the telemedicine visits using Mark's definition, the 99201 through 215, these visits pay more than the telephone-only to the traditional Medicare telephone-only telemedicine visits. Carrie asked, will this be recorded? Can I access it again? Carrie, if you are a member of the Thriving Urology Practice Facebook group, you'll be watching this live, and this will be available for replay as soon as I stop streaming. Carrie also asked, can I bill for a phone consult for inpatient? Mark answered that already using multiple codes. Even though I'm not familiar with those, I don't do much inpatient work. Omer asked, can urologists provide out-of-state telemedicine telehealth, even if you don't have medical license in that state. This is something that you need to absolutely be careful of. Even just because you can does not mean you should. There's several things to consider. One, the federal government says yes, you can freely help patients interstate. However, you need to watch your state regs, and also, almost just as importantly, you need to contact your medical malpractice insurer and ask for guidance when you are thinking about practicing interstate. I cannot stress that enough. You may not be covered medical malpractice-wise if you do not get that guidance. Vicus, why does CMS change rules for telephone encounters not billing? I cannot answer that. I am not part of the Department of Health and Human Services. Bill asks, would you be comfortable with us sharing this presentation with your coders? Well, if you are on the Thriving Urology Practice Facebook group, yes, you definitely can share this with your coders and billers. And also, as soon as I'm done with this, I'll chop it up and I'll send it up to YouTube. So, really, I just want to help as many people as I can. And I hope Boston Scientific is okay with this. If they're not, then I will understand, but I will definitely blast them and let them know that they should freely share this information. In 2020, to hold information as a commodity and hold practices and providers and coders and billers hostage because you want to obtain some monetary gain, it is total bullshit. Anyway, off my high horse. Vicus asks, so if it goes on time for new patient, is the same time element criteria as if you go by time, is the same time element criteria as an established patient? If you're billing based on time for new patient, is the time element criteria the same as an established patient? Well, you know what? Those are listed on the, if you look up CMS 1995 guidelines, you look up any E&M pocket card wall chart from PRS, it's listed on there. Carrie asked specifically, can I bill a phone visit only? That's been covered ad nauseum. Yes, you can. Holy cow. I think I went through all the questions. Wow. All right. I can't believe you guys are still here. All right. Let me see who is on the stream still. Oh my gosh. Quite a few of you guys. All right. If you guys have any questions, concerns, please leave them below. That's a ton of information. I am extremely grateful that Boston Scientific had Mark come on again to tell us the latest and greatest. I hope my take on things gives you a little bit of clarity, because when you have two people explain the same thing, sometimes you get it from the way one person explains and not the other person. So hopefully I can give you some guidance regarding your questions. Oh gosh, verbal consent document. I wrote down some notes, so I'm just going to go over that real quick. Gosh, it seems like all the questions, answering all the questions, I answered most of these. Oh, a couple of things. Number one, when it comes to telemedicine, when you are thinking about applying this or implementing this in your office, thinking through the workflow, just as you do in your office patient workflow. Thinking your workflow using telemedicine is going to be key to effective and efficient implementation. So I can't stress that enough. Maybe I need to do a collaborative Zoom meeting with some other urologists who are extremely efficient with their visits. I will tell you, it has not slowed me down, although my patient volume has greatly decreased, because I like to see new patients and I try to cure my patients. So my normal practice pattern is I see a lot of new patients. I mean, gosh, in the second half of 2019, I saw over 1,150 new patients. So that is my workflow. So I am suffering right now because I don't have a lot of new patients coming in. I only see urgent, semi-urgent, emergent patients like flank pain, gross hematuria, extreme urinary difficulties. I saw a couple of patients this morning with scrotal pain in young guys. So I want to see those patients so I can keep them out of the ER. And if I can disposition them here in the office, I certainly will do what I can. But the point is, I usually see a lot of new patients, so I'm not seeing a lot of established patients, and therefore my telemedicine consult volume is very low. I'm very, very happy to hear that some practices are up to 100%, which is phenomenal. And let's see. Oh, place of service 02. My from my reading and my experience and my understanding of CMS 1744, and if you're on the Thriving Urology Practice Facebook group, I did a Facebook Live yesterday. Just look on the discussion timeline. I did a Facebook Live yesterday discussing how Place of Service 02 is probably going to pay you the facility rate because of what CMS does, because that's what it is. And those of you who have billed Place of Service 02, you might want to let me know. Based on my reading of multiple physician forums, it is being paid at the facility rate and not the non-facility rate, which is more favorable to the practitioner. All right. I think that is, yeah, that's pretty much it. You guys asked some really, really good questions. Again, I will finalize by saying gratitude. You have to be grateful. I'm super grateful for Boston Scientific. I'm super grateful for Mark Painter and what I am able to do in this time of crisis. And I'm most grateful for all of you. I'm most grateful for all of you for doing all you do, contributing to the Thriving Urology Practice Facebook group, and also inviting your fellow urology practice people to join this group and collaborate and contribute. I can't thank you enough. I am blessed beyond belief. Gratitude will lead to happiness. If you are not grateful, you will never be happy. You can bank on that. Stay well. Take care. Bye-bye.